This is the Fertility Friday podcast, episode number 31. Welcome to the 31st episode of the Fertility Friday podcast. Thank you for joining me. I'm Lisa from FertilityFriday.com, and this is your source for information about the fertility awareness method and all things fertility. If you've been enjoying the show and you've been listening for a while, I would absolutely love it if you would take a moment and leave a review and a rating in iTunes. It would help the show to move up in rankings so more people can find it, which is always a good thing. And if you enjoyed today's episode, please stop by the show notes page and leave a comment. So you'll find all the podcast episodes at fertilityfriday.com/podcast. And you can find me on Twitter at FertileFriday. And I've recently created a Fertility Friday Facebook group. So just go to fertilityfriday.com/community and you'll be redirected to the group. You'll have to make a request to join, which goes through me and I'll approve you. And the group is in the initial phases. So I hope that with time, we'll be able to build a thriving and supportive community of like-minded women that will help each other in understanding and gaining confidence using the fertility awareness method. Sort of like what I had when I was learning, because when I was learning the fertility awareness method, I was part of a group of women, some of whom were fertility awareness educators, and some of whom were learning just like I was, and it was so helpful. So that's what I hope to create with the Fertility Friday Facebook group. And as for today, I'm so excited to welcome Dr. Danielle Miller to the show. Danielle is a family doctor who specializes in the area of women's health. She has taken a special interest in fertility and undergone extensive training to become a natural procreative technology medical consultant, which is way too long to say or remember. So it's commonly referred to as NAPRO technology if you haven't heard of it. And as a NAPRO physician, she has extensive experience with the fertility awareness method, and she applies the NAPRO tools to assist women medically when they experience fertility-related concerns. So I'm looking forward to learning from her today, as I'm sure NAPRO technology is an area that is new for many of you listening as well as it is for me. So without further ado, welcome to the show, Danielle.
Thank you, Lisa. Happy to be here.
Also happy to have you. So I did give you a bit of a brief introduction, but I'd love for you to tell the listeners a little bit more about yourself and your background and what inspired you to learn about fertility awareness through NAPRO technology.
Sure. Well, as you mentioned, I'm a board-certified family physician and had no real knowledge in any of these topics at all during most of my medical education. So I went to college and then I went to medical school. It was during medical school through friends that I heard about fertility awareness-based methods for the first time. And that really caught my attention and was exciting and surprising, and I became interested in learning more. So it was during medical school that I heard about fertility awareness-based methods and became interested in perhaps learning one of these methods for myself. I never learned anything about fertility awareness during my medical school education, and I learned very little during my residency education, in part because there were residents ahead of me who knew a lot about this work. So it was then during medical school I found an interest in this area, and during residency I took the time, actually designed an elective course on fertility awareness-based methods and medicine, and started my training in NAPRO technology during that time. So I started it in residency, finished it after residency, and now work full-time in family practice where I incorporate this into my work with patients.
Wow, that is, I don't know, I think that's so cool that you took the initiative to design a course to teach it as well.
Yeah, it was, we get very little, I guess, free time during medical education, but the time that I had, I was really interested in learning more. And I think for many of us who get involved in any fertility awareness-based method, we get pretty enthusiastic and excited about what we're learning, and we have to make the time to learn more, or else it doesn't just happen on its own. So I had 4 weeks that I could take during residency and do some independent study, and that was when I started my NAPRO training.
That's awesome. Well, as my first medical doctor, I'm thinking, but yes, you're my first medical doctor on the show. Obviously, you probably are aware as much as anybody else that often women who are using fertility awareness or contemplating it when they approach their doctors, often there's kind of a serious lack of knowledge and support in that area. So one of the questions I had is, how did you find the reaction of the medical community, your fellow students, and now your fellow colleagues to your approach using natural methods of birth control?
Wow. That is a strong question, I guess. Yeah, so, I guess I can say, first of all, that it's something that many people, of course, as your listeners know, don't really know about this. We find ourselves kind of the first person on the island, if you will,
Yeah.
in this area of knowledge. And then people flock to us and all want to know more, oftentimes, not always. But yeah, it's interesting. I mean, I learned about it through friends in med school, and it was sort of undercover. I mean, it wasn't something that was part of my education, formal education at all. And then everybody else who weren't these couple of rare friends thought we were crazy. I knew through these friends that people were actually charting their cycles to avoid or achieve pregnancy, and it worked. And I guess other people that heard about this just didn't believe that. So I guess, I can say that there is been thinking about, what are the barriers with those of us in the medical community to even learn about this? And I think there are two real barriers, if I could just put this out there and then talk about the reaction of my colleagues and peers since. But I think there are two real barriers with doctors accepting these methods. One is that we are taught, and really the only thing we are taught formally about fertility awareness-based methods is that they're ineffective. So if and when they are mentioned in medical school, and really mentioned for about 1 second of one lecture, we get hours and hours of birth control and contraceptive lecture series, but we get 1 second of fertility awareness. And people say the rhythm method is ineffective. And they refer to all of fertility awareness as the rhythm method, which of course is not a true statement. Nobody actually uses the rhythm method anymore. And at the time where it was popular in the 1950s, it was the most effective form of family planning available.
Oh, geez.
Which is interesting. But also, we're told that fertility awareness or rhythm is 75% effective. So this has largely been popularized by one or a couple authors in one medical textbook, which is considered the authority on all things family planning or birth control. So there's a book called Contraceptive Technology by doctors Hatcher, Trussell, and their colleagues. And contraceptive technology cites a 76% efficacy rate of fertility awareness-based methods. So that one statistic seems to be the only statistic in the general medical literature on these methods, which is really kind of interesting that just one statistic has really dominated mainstream medicine. We're in such an age of evidence-based medicine, but somehow you can't be evidence-based with this. It just isn't allowable.
No.
To their credit, the authors have recently, in more updated editions of their book, they have actually listed a few different fertility awareness-based methods specifically, and they have cited perfect efficacy of those individual methods. And those perfect efficacies rate from 95 to 99.6% efficacy, which is remarkable and you would think would be turning heads.
Yeah.
But really, when they describe fertility awareness-based methods, they generally regard them as ineffective, and they cite that summary statistic of 76%. And I think it just sets the tone.
Yeah.
I think the other important strike against fertility awareness-based methods from the medical community is just the idea that doctors have around patients and patients making their own choices and decisions. There's a lot of stress that doctors often feel when their patient becomes pregnant, and either the patient and or the doctor did not expect that pregnancy.
Mm-hmm.
So generally, we are taught of pregnancy as a medical failure.
Oh, lovely.
And the methods that are really promoted and touted as highly effective are those that are implantable and temporarily irreversible, or those that are permanently irreversible. So what I'm referring to is, methods like IUDs or Nexplanon or sterilization. In recent years, long-acting reversible contraceptives, also called LARCs, have just been really popularized and infiltrating. And I think it's this fear that doctors have that they don't want to fail, and pregnancy is always a failure, so they want to put in something that is irreversible temporarily or permanently, which, that's one approach towards sexuality.
Yeah.
But I think that, people are complicated and people's relationships are complicated. And sometimes people choose not to use a pill or a condom because they actually don't want to avoid pregnancy at that time.
Yeah.
And I think human behavior is complicated. And so I don't get afraid if my patient has some ambiguity about pregnancy the way I think a lot of my colleagues do. But I think there's this fear to trust the patient in regards to her own sexuality, which is the other reason why I believe fertility awareness-based methods are not advocated by providers. They don't trust their patients to decide what's best for her or him.
Yeah. Well, and with fertility awareness-based methods, which it's very sad to me that they all get lumped in because yeah, if you take like 50% and you add it to 96% and you divide it by 2, you you get 75%. But side note, but the thing with the fertility awareness method is that it's user dependent. It only works if I work. It only works if I actually do what I'm supposed to do. If I understand exactly how it works and if I have a correct and accurate understanding of it as well as a correct and accurate application of it. So I think that's just a lot of variables for a scientifically minded human being such as a doctor.
Yeah, I mean, I agree with you. I mention fertility awareness-based methods to every patient, or I try to with every patient who asks about preventing pregnancy or planning for pregnancy. And I try to describe it briefly and say, if you use it and learn it, it'll probably work. Just like if you use a condom and every time you have intercourse and it doesn't break, it'll probably work.
Yeah.
And patients understand that. They understand that if they don't always use the condom, it won't work.
Yeah.
There's a basic literacy to, I think patients are just much more accepting of these methods than doctors. But it's just a funny thing about these methods. So, we're taught that they're not effective, and we're also taught to never trust a patient and to never put the decision of pregnancy in their hands, which is kind of a weird thing to think about another human being.
Is that direct or is that indirect? Is that like the message that you get or is that what it's actually told?
I think both.
Wow.
Yeah.
That's so enlightening. But I guess, I know we're off topic, so we're going to get back to NAPRO, but is there a fear of the patient coming back and blaming the doctor to say, you gave me this and it didn't work and now I'm pregnant and it's your fault type of thing?
That's an excellent question, Lisa. I think that is part of the fear. What I hear more often from doctors is that such and such patient got pregnant and I can't believe she got pregnant and she wants to keep the baby.
Wow.
I really wish she wasn't pregnant.
Oh my goodness. That's like so hard to hear. In the set, like from some, you know what I mean? It's so like, because as you mentioned, human behavior is complicated and there is a lot of ambivalence around pregnancy. I mean, it's safe to say that some women are kind of on the fence of whether or not maybe they want a child at this exact moment. And so instead of making that decision, they kind of let that decision be made for them by kind of knowingly not using the method correctly.
Correct. Yes, I agree with that.
So that's a thing. It's real.
Yeah.
It happens.
I completely agree.
And obviously, you, pregnancy and babies are something that's it's just not as black and white, cut and dry for everybody. Some people it's very cut and dry, I'm and other people it's I mean it's a very personal decision. And some people who do everything to the letter, um, you know, that 1% that still get
Yes.
pregnant. So
Yes. And I think people are all very different, and seasons of life are different, and sometimes hours of the day are different,
yeah.
Yeah. So, given the background of these methods not thought to be effective and also not thought to be something you should ever trust, because you then are trusting your patient with these methods. It's just a kind of an uphill battle if you're a doctor who's interested in these.
Yeah, I can see that.
But I think as my training has continued and I've gone from the academic world to real life, where I'm treating real people every day in and out of the office, I think actually the acceptance is somewhat better. I think patients are actually interested in these methods much more than we give them credit for.
Mm-hmm.
And I think that my colleagues are sometimes asking me, oh, hey, do you have that fertility awareness handout that you give? Because my patient is interested and I don't have that,
Mm-hmm.
And so they might think it's a little off the beaten path, but they see that there is at least perhaps some small value to this interest in women's health and reproductive health.
Well, I'm thankful that you're out there in the world, because the impact that you have just by having this knowledge and operating your practice the way that you do, kind of that indirect impact, is more far reaching probably than you could even imagine. I'm sure some of your colleagues probably wouldn't, but if you think about it, if they hadn't been exposed to you and kind of know what you're doing, they may not have been even in the place where they would have had a pamphlet to even stock their office with, right? So I think there's something to be said for that. But let's talk a little bit about NAPRO technology, because
Sure.
it's something that I've heard of. It's kind of on my radar, but I haven't had an opportunity to really delve into it and really learn exactly what it is and how it works. So maybe you could talk a little bit about what it is.
Yeah, absolutely. I guess it's hard to know where to start. NAPRO technology is a medical science that is based on a specific fertility awareness-based method. Could I start by saying that briefly?
Yes.
Okay. So again, another really long name, but I'll say it out loud once in its entirety. The fertility awareness-based method, which NAPRO is built upon, is called the Creighton Model Fertility Care System.
Okay.
Or you could simply say Creighton Model, or I usually say Creighton.
Yeah.
Okay. So Creighton is a fertility awareness-based method. It is a mucus-only method.
Okay.
So this is a mucus-only method that teachers undergo extensive training on. Actually, the training is very similar to the training I underwent as a medical provider. They have more case-based management. I have more medical management, but the training is actually quite similar. And that methodology and family planning fertility awareness-based method was in existence for about 30 years before NAPRO technology was formally, I guess, originated. Okay, so there is an American obstetrician gynecologist named Dr. Thomas Hilgers, and he developed both the fertility awareness-based method called Creighton and NAPRO technology. He's still in practice. He's the lead physician at a very large NAPRO center in Omaha, Nebraska, and he works with his colleagues not only to deliver services to many women and couples from all over the world who come see him in Nebraska, but also to deliver this teaching program to those interested in learning to become teachers or practitioners, as they're referred to, and those interested in becoming medical consultants with NAPRO, which is what I've done. So NAPRO is a medical science. It's a medical approach to women's health, in short. But of course, we have general obstetrics and gynecology and general reproductive medicine. So how is it different? Well, that's a really good question. It's almost very simple and very complicated to answer. NAPRO technology is different. You could summarize it by saying that it is a cooperative, restorative approach that maintains a woman's normal reproductive health. You could also say that if a woman presents with a problem such as abnormal bleeding, some other cycle problem, infertility, miscarriage, many others, NAPRO technology will try to find out what's going on, why she's having that problem, and then fix the underlying issue and restore her normal gynecologic or obstetrical health. That sounds really basic, doesn't it, Lisa?
It does, but I think the concept of it is quite profound in the sense that I'll give you the opportunity, of course, to get into it a little bit more. But so if you're working with a woman who's charting her cycles with Creighton, and so maybe actually you could talk a little bit about it. So when I talk about the fertility awareness method, of course, my background and training was through Justice, which is mucus, basal body temperature, as well as the optional cervical check to check the position of your cervix. So Creighton, you mentioned, is mucus only. So maybe you could talk about that a little bit and how you work with women with their fertility awareness charts and actually apply medical science to it. I wish that all medicine would incorporate these two things because I feel like there's so much opportunity to help women, of course, with the information that they have from their charts.
Yeah, absolutely. Could I start with kind of an example outside of women's health briefly?
Oh, sure.
So I would say the general approach towards women's health is not to identify the underlying problem and restore normal function, okay? This is how all the rest of medicine is, except women's health, okay? So I just want to give a quick example because it might, maybe it will drive the point home. And then I'll talk about how NAPRO works. If somebody presented to the ER and simply said, I had chest pain, and they went and got bypass surgery, and that was it. They said they had chest pain and they got bypass surgery. That might not really be a good idea, okay? Let's say that the cause of their chest pain was pneumonia or a rib fracture or gastroesophageal reflux or a stomach ulcer. You know, I mean, this is not something that we do in any other area of medicine except women's health. You know, when a woman presents with an abnormal cycle of any kind or a cycle-related problem such as pain or PMS or whatever it is, she's offered a hormone suppressive therapy. Or if a woman presents with infertility, she's often offered little or no workup and then an IUI, intrauterine insemination, or IVF, in vitro fertilization approach. But we don't actually find out why the woman is having menstrual pain, long irregular cycles, infertility. We don't give women the answers they seek. So I just want to say that it's only acceptable in women's health for the medical community to ignore all the differential diagnosis options, to ignore all the workup, and to give a one-size-fits-all treatment approach to most every patient we meet. And I just think that's really not the right thing to do.
I couldn't agree more.
So I just want to say that that's the difference between NAPRO technology and sort of the mainstream approach towards women's health, which is really a sad thing to say that women are stuck in this place of not being treated like adequate patients in regards to their reproductive bodies. So how does NAPRO work? I would say that we tend to treat women's health like we do all the rest of medicine. We really focus on taking a really good history, doing a really good physical, and then we have the wonderful advantage of having a patient who is charting, which is just delightful and allows us to do a lot more than when she's not charting. Most patients are actually charting Creighton. Maybe their practitioner referred them, or they have self-referred and wanted an approach like this for their gynecologic or infertility problem or other. But sometimes I will encounter a patient who is using a different charting system, and she's happy to explain to me the details of her chart that I'm not familiar with, and we can do our best that way. So once we have the tools of the patient telling us all about what brings her or the couple in, and we do a physical, and we've got this great chart, which is such a wonderful resource in front of us, then we can actually do a really focused workup, okay, which is exciting for both the patient and the doctor because we can actually find out what's going on. So workup generally includes things like labs and ultrasound. And it really depends on the problem in terms of what kinds of labs and ultrasound are needed. I guess maybe using an example might help. So it's easy to sort of use the example of infertility. Infertility is a symptom of one or more underlying problems. It is not actually a diagnosis in and of itself if you really think about it. Sometimes women are offered a day 21 progesterone level when they have an infertility problem. I don't know if you or your listeners have ever heard of that. Mm-hmm. It is meant to capture a peak or a very high progesterone level about a week after ovulation. That's the goal of it. However, if any of your listeners chart or have ever known anyone that's charted, she might know that women don't ovulate on day 14, some or all of the time. And so trying to capture this high peak progesterone level on a random calendar day may not actually represent anything medically useful at all. It also doesn't give you an idea of her whole luteal or post-ovulation phase. You can have progesterone deficiency before or after a peak day with a normal peak level, even if you happen to guess the right day, which would be kind of unusual. And so, that's sort of the lab approach might include capturing one female reproductive hormone on one day of the month, not timed to her cycle, which is pretty sad. Mm-hmm. Laboratory approach through NAPRO would be frequent labs during the fertile phase, looking at estrogen, because that's what's going to rise and fall around the time of ovulation. And also looking at a series of hormone labs after ovulation, both estrogen and progesterone, because each should have its own specific curve where it rises and falls. And there are different hormone abnormalities that exist in multiple ways, both during the time near ovulation and the time after ovulation. And so we take a targeted hormone approach and we obtain a hormone profile. And women, they have a few blood draws in the month. They might have perhaps around 10 plus minus total blood draws for the month. And of course, that's a lot. But women are generally really looking for answers, and they're okay finding out the answers to their underlying problem. And I guess ultrasound is very similar. Some women will be offered one ultrasound some of the time if they're having infertility or another problem. But if we're looking at an issue like infertility, it's not just what her reproductive organs look like on one day of her cycle, but yes, we want to know baseline what do her organs look like, but a NAPRO physician is interested in ovulation. And is ovulation occurring at all? Is ovulation occurring normally? So NAPRO technology has identified several different ovulation disorders which are not going to be captured on a one-time ultrasound. You actually have to follow a woman through the time where a few different follicles start to develop. One is going to chosen to be the dominant follicle for that month, and then it should rupture in a normal way, and the ovary should have a normal appearance after rupture. But you can really identify some serious issues if you do more than one ultrasound for the month and really focus on that follicle and that ovulation. So that would be the difference with the approach in terms of workup. And then the problems are usually identified, which is the whole point. And then if you know what's wrong, then you can use different medical and or surgical therapies to treat someone who may have an abnormality.
Okay. I think that the way that you described, it's almost like my perfect alternate universe, because because as someone who's charted their cycles for so long. As you know, I've charted my cycles for 12 years. So you get a different understanding of how your body works. And so I think for a lot of people who might not have this background, when they hear you say, talking about how you could map the woman's cycle, perform tests based on what's happening in her body at the right times to capture the right information so that you can see exactly what's happening, what's wrong, and the difference between that and taking a random test somewhere, that's lost on most people. It's lost on most physicians, not for any fault of their own, but because this information was never provided to them. And unless you have the opportunity to learn about how the female reproductive system works and how female fertility works, it's just missing. It's just that it's not there. And so what you just talked about is so profound. And I think that women really need to be able to learn, just to learn how this works. And ideally, hopefully in the future, this can kind of leak out into med school so that women are actually being treated. Maybe you could talk a little bit about, maybe even give an example of a certain condition or something like that that could be identified and how it's treated. So after the condition is identified, what steps are taken to kind of address some of those issues?
Sure. So infertility is one, which I won't focus too much on just because there's so many different underlying problems that can occur. So I'll briefly mention, just that perhaps someone does not have cervical mucus at all. Perhaps they have absent cervical mucus. That would be a cervical factor contributing towards their infertility. That would be a problem. And actually, it's pretty easy to increase cervical mucus and improve quality and quantity just through some dietary or medication measures. It's actually not too hard to do. There could be someone with infertility who has maybe a really short time after ovulation, not enough time for her uterus to mature and be ready to sustain an embryo in the early stages of pregnancy. So you could address the luteal phase. There's really lots of different causes that can be identified and then treated specifically. Maybe one problem that comes up perhaps with infertility, but also outside of infertility, I'll see a lot of women who are having irregular cycles. And it is a challenge when perhaps a lot of these women will come and see me and say, I'm having irregular cycles, and they don't even know how to describe how they're irregular. They just know something is wrong.
Mm-hmm.
And I'll ask them about their cycles. And for example, one woman, I've been bleeding for the last 30 days. It's not right. Okay. How were things before that? They were fine, but you get more information, and she's had bleeding every, 3 to 12 months since menarche at age 13. And you think to yourself, well, that's actually not normal either.
Yeah.
So just to say that, again, just the charting can be so helpful. So when I have a patient who presents to me with irregular cycles and she's already charting, or she then learns to chart, we're able to have this common language to describe how her cycles are abnormal, the length, the frequency, the regularity, the type of bleeding she's having. This is all sort of documented and can be discussed. Sometimes with long irregular cycles, you're wondering, does the patient have a problem like PCOS or PCOD, polycystic ovarian syndrome? Or does the patient have a problem like hypothalamic amenorrhea or infrequent menses? Those are two very different problems. One, the hypothalamus is underactive, and she has these long, infrequent cycles. And the other, you have a serious imbalance of her hormones in the way of polycystic ovarian, and you need to get them into balance. But it's not that she has very little estrogen and progesterone, in their entirety. So you might actually see, based on a bleeding pattern, you might be able to distinguish some. But again, I guess there's just a lot you can learn when someone's charting, and then you work them up to either confirm or to newly diagnose what you think the underlying problem is. Did you want to talk about treatment at all, I guess?
Yeah, we could talk a little bit about the way that the way that you address these issues with NAPRO technology, from what you said, it's a combination of, like a medical approach, potentially surgical, depending on the specific issue, and sometimes dietary changes and those types of things.
Sure. Yeah. I will say that there are some NAPRO medical consultants who are OBGYNs. I am not. And some of them have had additional training beyond the medical consultant work. They've actually done fellowship training in surgery. So those are, in my mind, the most thrilling surgical referrals I can make because it's a surgeon who is trained, again, should be really basic, should be really not just a NAPRO thing, but they're trained minimally invasive, low adhesion, meaning low scar formation approach towards really complicated problems like endometriosis or ovarian cyst, recurrent ovarian cyst. Endometriosis, a lot of surgeons don't want to perform corrective surgery for because they end up scarring a woman's body so badly. But NAPRO surgeons are just really skilled at not scarring the body and eliminating endometriosis completely or near completely in a way that is just outstanding. And I don't see that amongst any other surgical colleagues of mine. So that's just one thing to say that, NAPRO surgery is really very much a different type of gynecologic surgery than, again, a general women's health approach towards gynecologic surgery. But yeah, I think there's a lot to do, certainly for me and my colleagues as NAPRO medical consultants. I think diet has a lot to do with a lot of different problems, and I try to talk to my patients about what they're doing with their lifestyle and what might help. And I do my best. I'm not a nutritionist, but sometimes wish I had a lot more to offer, but at least I can refer someone in some basic direction. I can give them some books or internet resources or other sort of options to learn more. And also, I do think medication, I guess I'm a physician. I think it has some redeeming value.
Of course.
I think it has a place. And so one medical therapy that I guess might be useful to talk about is something like progesterone. Progesterone is a commonly used therapy by NAPRO providers. It is perhaps occasionally or rarely used by my non-NAPRO colleagues. A couple things about progesterone. One would be that NAPRO providers generally only use bioidentical hormones ever in their treatment of these problems. And as your listeners may or may not know, any contraceptive product that is hormonal will contain artificial hormones that are not bioidentical. They will have estrins or progestins, which means that they are hormones like estrogen or like progesterone, but there is no hormonal contraceptive that has bioidentical hormones in it at all. And also, some doctors that do progesterone support, perhaps in something like the case of pregnancy or trying to prevent preterm labor or something like this, a lot of gynecologic colleagues of mine will use synthetic hormones in that case as well. And in NAPRO, we won't. We'll only use bioidentical progesterone. So that, I guess, would be one difference, again, in our approach. We do know, and anyone who looked at the data would know that bioidentical hormones obviously act in the same way as when they're, taken into the body as the hormones that are already existent in the body. However, these artificial hormones, which NAPRO commonly calls artemones, actually have different biologic activity, which is true and which is commonly available knowledge, but just not sort of thought to be important, I guess. But they actually have different effects on the body than the bioidentical hormone. And so that, is a possible concern for patients and providers. But progesterone support is really pretty awesome. I find it very useful for many patients of mine that have PCOS. Progesterone support can, over time especially, really normalize their cycles and improve their rates of perhaps fertility, ovulation, and certainly, of course, cycle length and bleeding patterns are dramatically improved with progesterone, without a doubt. Progesterone also plays a role with someone who might be having severe PMS. We can often identify that she's really deficient in progesterone, again, during that post-ovulatory phase or luteal phase of her cycle, and progesterone support might be a great help to her. Recurrent miscarriage is one, preterm labor is another. And a shortened luteal phase, perhaps someone only has maybe 5 days after ovulation before their next menses. Progesterone can help lengthen the end of that cycle, which can really improve a woman's cycle and other problems associated with that short luteal phase. So progesterone, I would say, is a commonly used medical therapy in NAPRO and really with good success.
Mm-hmm. Well, I was thinking about something that you said earlier, which is that in kind of the traditional approach, woman goes to doctor, she's struggling with infertility, and then it's kind of, as you mentioned, IUI, IVF, kind of going that approach quite soon. It's kind of like, if you're not getting pregnant, then this is what we do. I guess the question that I have is, when NAPRO, maybe you could talk a little bit about how successful NAPRO is in terms of, when women are struggling with infertility, how many are able to kind of overcome it through this whole process. But for the women that do go on, for whatever reason, and still require the additional medical intervention, so still having to go on to the IVF, IUI path, how can this knowledge of a woman's cycle, does it have an effect on IVF? Can if the doctor is informed about how the cycle works, does that help to change how they time things, or does that play a role in those processes at all? Maybe you could touch on that a little bit.
Yeah, those are great questions. Again, it's a difficult to answer in sort of a one sentence or one number, because actually, again, infertility is such a complicated problem with so many different underlying causes. Yeah. Generally, the approach with NAPRO is about as successful or more successful than other artificial modalities. So some certain underlying causes have outstanding success with NAPRO compared to IUI, IVF modalities. And then there are others, perhaps it's a situation like azospermia, meaning the male in the relationship has no sperm to speak of. NAPRO is not probably going to enhance that couple's chances of conception and carrying too well, okay? And so I would say, yes, every system has its pluses and minuses. That would be a limitation to NAPRO, that it would not, and I guess I couldn't say zero chance, but there are some really, really neat cases within NAPRO that colleagues of mine have had, where a man has severe decreased sperm count and the provider is able to increase the sperm count and they conceive and carry well, and that's exciting. I'm not sure I'm aware of a zero sperm count. But yeah, generally the success is as good or better for most scenarios within NAPRO. Again, we're looking to restore normal function. Issues like PCOS are really highly effective with NAPRO. And I can double check. I think I have some numbers here because I wanted to be able to give you a comparison like that. So success rate with PCOS is going to be at least 60%, and comparatively with perhaps an IVF cohort, about 25%. So, that's really not great for the IVF colleagues who maybe think that they are the only answer. Certainly they're an option, but I would say perhaps not the most highly effective option. So I would say it really does vary based on the cause. And then you asked this really good question of worlds colliding. I guess I can say first, you mentioned the couple that perhaps won't conceive with a NAPRO approach. And absolutely positively, although we have better than 50% success rate overall, and varies maybe between 60 and 80% depending on the problem, there are going to be people with any modality, NAPRO, IVF, whatever it is, that are not going to conceive and carry. My experience with patients and my colleagues' experience with patients has been that the patients are actually fairly satisfied with the experience. I find that they feel as though they have done everything they can. Every stone has been unturned, and they're actually pretty well at peace with it, to be honest. They feel as though they tried all the cooperative medical approaches they could, and that actually satisfies the questions of why and how and why isn't this happening. And that's actually, it's, I think, a good experience for the patient and the doctor when the patient is not angry at you or angry at herself or her partner. I think what I hear from patients, I often see folks who go to a reproductive specialist and they are offered IUI, IVF, and either choose not to do it or fail at that method, whatever that means. And they are not at peace at all, actually, because they feel like nothing was done, except their body wasn't working to begin with, or bodies, depending on if it's a dual factor or just the one of them. But they feel as though their bodies weren't working to begin with, and nothing was done to find out why or how, and something else was tried that was not cooperative with their body, and then they're still broken at the end of it. So I find there's actually not much peace at all when they come into my office, and they're thrilled to find out that we're going to try to figure out what's going on and deal with that. So yes, it's true. If somebody goes through a NAPRO workup and then isn't able to achieve and or carry, they of course can go into other options like IUI, IVF, or other reproductive specialty options. I find that when they work with those providers, the providers really, truly are not interested in when they are ovulating on their own.
I kind of had a feeling.
I mean, it's really a challenge, Lisa. These women are smart women. I mean, I think women who chart are really, they know what their body is doing, and they have a sense of what's happening. They may not know every detail of it, but they are frustrated because most of their providers would rather shut everything down with something like an oral contraceptive or a medication like Lupron, which puts you into temporary menopause. And they would rather start the patient over with no cycle. Then they would like to hyperstimulate their ovaries to hyperovulate them and sort of dominate the process that way. I mean, it's just a really challenging approach for patients who are so well informed and told that knowledge doesn't matter because it doesn't fit here. Again, that sort of one-size-fits-all approach, which I hear patients tell me they are frustrated by.
Yeah, well, because I had an experience where a friend of mine was telling me about her experience, and she mentioned that she's going through IVF, and she mentioned that she was on the pill. And of course, I blinked a couple times because I didn't get it, because I'm not a doctor, so I don't, but then she kind of explained to me that that's how they regulate, quote unquote, I love that word, with in reference to the pill. I love the word regulate, since it does no such thing. But that's the approach, just like you mentioned. And for someone, as you mentioned, that does chart and understands what's happening in their body, it seems counterintuitive to me. Obviously, well, because if a woman is trying to get pregnant and she's having fertility issues, why is she on the pill? But that's the approach.
Because the goal is not to restore her normal body function and allow
to bypass it.
Correct. The goal is to bypass, suppress, or destroy her normal function. Almost always, it seems, with women's health. It is really weird. I mean, truly, this is strange. We just don't do this in any other part of medicine. We don't shut down something that's working or make it worse, like debilitate it more to fix it from not working.
Yeah.
And again, really, Lisa, what I think of with these, and I hear this all the time from patients, oh yeah, I went on Lupron or I went on oral contraceptive before I underwent my fertility treatment. I hear it all the time as well. I have to be honest, the first time I heard it, I was like almost fell off my chair in the office when somebody was telling me this. But then you learn, of course, this is what is done. This is the standard of care, if that even is a phrase that you could use here, but that is what we would call it, the quote, standard of care. But again, I really think, if I can put my opinion on this, that it is a fear from the doctor of loss of control. Like when we talked about fertility awareness-based methods as a whole, I really think the reproductive health specialist is trying to control the woman's body in a predictable way. You cannot say that he or she, the provider, is regulating the body.
Nope. You can't regulate the body. Can you regulate the body?
Oh, well, I guess I don't know. But that's not what it's doing. Just like you said, I don't know the answer to that. But the provider is controlling the body.
Yes.
Is controlling and manipulating the body into a predictable outcome.
Yeah.
Such that the next step can be controllable and predictable.
And that's probably why, often, unless it's successful, women aren't necessarily, even if it is successful, maybe women aren't necessarily satisfied with the process. Because as you mentioned, they're treating the body, not the woman, not the patient. So if I come in and I have XYZ concerns and I have anything to say about the strategy that you are planning to go ahead, I'm a bad patient. And the doctor won't really tolerate much of that.
Isn't it sad?
It's true.
But isn't it sad that patient and doctor become enemy because she's trying to treat or fix herself and he's trying to control an organ or set of organs?
Yes.
And with no regard for her. I mean, it really is sad. We're taught to be a profession, caring for patients. We're taught to do no harm. And that's really not what I see. I see a lot of this methodology in regards to reproductive health really as a business that controls women's organs and body parts. I can't even say it controls her body because it doesn't. It controls parts of her body.
Yeah.
And his. I mean, clearly his too. I hear the same experience from men. They're not satisfied with the process either, really. It's just a challenge. I wish well to any patient or person that I meet. And it's a challenge that even when it works, meaning they conceive and carry and all this, women tell me all the time about their experience with IUI and IVF and just how physically and emotionally exhausting and sort of the destructive approach of it has long-lasting effects on her and or the couple. They're exhausted. And a lot of them say, I won't do it again. I don't care. Yes, we wanted X number of children, but I'm not doing it again.
Mm-hmm. Well, there's a lot of aspects of it, that are physically uncomfortable, that are to some degree humiliating.
Yes.
I think we've all, as women, to some extent, just come to, just accept certain procedures, say. But as I mentioned, as a friend of mine was describing, friends, plural, of mine were describing some of the procedures involved for identifying issues and, basically the pre-IVF procedures that they're having to go through. It's extremely invasive, some of them, and some of them are extremely uncomfortable and just extremely, even the timing. A friend of mine mentioned that the timing, there was a required ultrasound while she was menstruating, and it's humiliating, it's uncomfortable, it's invasive. Even for the man, I mean, I had an interview with Mark Sklar, and he was talking about, basically like, well, it's not really that big of a deal for men because they just have to go and ejaculate, right, into a cup when, in these procedures. But with that being said, some men aren't necessarily comfortable going into a strange place and just having to, like ejaculate into a cup. So the whole process can be, especially repeated times, depending on how many times that has to happen. So I think that there's something to be said for not really feeling like a person in the process.
Yes. Very much what I hear from men and women all the time is that they feel like someone who has this organ or body part that has failed, and that organ or body part is being manipulated, and they're sort of at the mercy of the doctor who is manipulating it, and it is extremely uncomfortable on their whole person. I mean, if you can imagine I really do feel for these women. Their bodies are thrown oftentimes from abrupt menopause. This is a woman of reproductive age who has some fertility at baseline, even if she has, quote, infertility. It's not the same as menopause until you're in menopause. But she's thrown from some status of reproductive function into abrupt infertility, menopause, and then she's thrown into hyperovulation. Again, this is what I hear from women oftentimes. Not everyone is hyperstimulated or hyperovulated, but that's a commonly done route to obtain multiple eggs at one pass. And these women, they lose weeks from their life, their work, their due to pain, discomfort, sometimes vomiting, sometimes occasionally ER visits and or hospitalization for pain or complications. It's really wild what they physically go through, never mind emotionally. It's unbelievable.
Mm-hmm. Yeah, I think when you were talking about the NAPRO approach, and it seems like kind of this perfect marriage between fertility awareness, and I think for the listeners who've listened to the podcast episodes that I've done, I always talk about how when a woman charts her menstrual cycle, it can be used as a tool to identify health concerns. And I think that what you've talked about today really drives home how important this information really is in terms of being able to identify so many different health issues, fertility related concerns, and just the power of having that information and having that knowledge. It can really empower you as a physician. It can empower, me as the patient, and really help to get the answers that we're looking for. Because as you've alluded to as well, as a woman, I can't speak for all women, but you want to know what's wrong. We all want to know why. That's the first question out of our mouths when we're feeling frustrated if things aren't happening the way that we think they should be. The first question is why? Like, what's wrong with me? What's happening here? Why is my body not functioning the way it is? And the approach that you've discussed today really it shows that this is an approach that's actually trying to find out why specifically, so specifically that it's looking at your specific menstrual cycle and testing you at specific times so we can really find out what's happening with you. And I think I hope that that's something that becomes mainstream one day. That would be amazing if every single doctor was trained in this way, especially or fertility specialists were trained in this way. So we could really have more success and just more satisfied patients, and also just a higher standard of care, like you mentioned.
Yeah, I think you're exactly right. This is what women and men are looking for. And it's really not so wild, except it's just not offered. And I do agree, it shouldn't be a niche specialty. It shouldn't be this microcosm of physicians who are trained in this. It really ought to be basic medical curriculum, just the way working up chest pain or any other abdominal pain. This is so basic. We just really don't tolerate this type of limited or eliminated workup at all in any other field. And honestly, I feel that I have a friend that says women are smart and, women can make their choices and they're smart. And I agree with her. I just find that when women are only offered perhaps a suppressive hormone treatment or an artificial route as the only option towards her presenting gynecologic or infertility problem, it's just a challenge for the woman or couple because, one, they feel like it's the only option. Mm-hmm. And that's really challenging. You're given no choice at all. Yeah. So some women go through that option and really they're not supported much at all. And that's something that really ought to change in the IUI IVF world as well. We ought to have people supporting these women and couples. They're left in the dark. They have no idea what the next step is and how it will feel or affect them to go through those next steps. That's a real horror as well. Just don't hear a lot about caring in that regard. Healthcare. So, these women have one option of maybe taking a hormone treatment or whatever it is. Or let's say the woman tries that route, that's one thing, or she doesn't. And then she feels as though nothing has been accomplished at all.
Yeah.
She's given one option for her complex problem that needs to be figured out. She doesn't hear anything about why or how. She either takes the route, and that may not be the best fit, or she walks away with the same problem and no treatment at all. And that's just really not fair. I think all the available options should be offered to all patients. That's sort of basic informed consent. And as a doctor, I didn't really know much about this until a few years ago, and so I can't say that the doctors are deliberately not telling their patients, but they really don't know. So they're offering the only option they know. Um, and that's sad too. The whole system, like you said, is kind of broken and really needs to start with basic medical training.
Yeah. Well, as time goes by and as more physicians learn NAPRO technology and fertility awareness becomes more of a mainstream concept and idea, and as more women choose what's works best for them and realize their different options, hopefully we'll see a change in the way that matters of fertility and infertility are addressed. And so, just to kind of wrap up today, I just have a couple questions to ask you. So, one of the questions I wanted to ask is, what do you think is the biggest myth about fertility?
That's so broad. I don't know where to start. Fertility?
Well, maybe something that if you could change something about the kind of common beliefs about fertility, something that particularly bothers you, what would you want to change?
You're not saying fertility awareness. You're just saying fertility.
Yeah.
Okay. I'm gonna go with what I'm thinking, because I've been recently thinking about this very concept, at least my answer to this concept, to a friend lately. um, I think fertility is both complicated and not. Okay, I think that there is a rhythm or a cycle to every woman, and I think that there's only, in some ways we're all very different. In some ways we're all very much the same. I mean, in some ways, each of us is trying to menstruate and or ovulate. And there's just, some variations on that theme. I think hopefully most of your listeners know the 28-day cycle is a complete myth. But there are some normal things that happen, and there are some abnormal things that happen. And so I guess if I could say one thing about fertility that I wish someone knew, or that I could change, or that people don't know, is that every woman has her own baseline fertile status, and that is discoverable, and that is learnable, and it can be changed. It can be changed by her environment, stress, what she eats, how much she exercises. It can be changed by medications or surgery. It could be changed by the circumstances of her life. But I think fertility is it's a wonderful thing that women have for many years in their life. And I think with approaches like NAPRO and with charting opportunities in fertility awareness-based methods, women can learn about their own fertility, and it's not so scary. I guess that's the myth busting. Fertility is not there's this quote from an old medical textbook. I'll try to not completely botch it. Something like conception happens in a deep, dark, mysterious place, or something like this. And I mean, that's sort of true, but sort of not. I mean, I guess there's not lights and cameras in the fallopian tube when conception happens. But by the same token, fertility and women's health is really not too awfully mysterious. Each woman has a rhythm, and that can be learned, and that can change depending on what's going on.
I think that's very profound.
I
do. I really do. I think actually on the same vein then, what would you say is one of the biggest myths about the fertility awareness method or fertility awareness based methods that you would like to see corrected?
Yeah, I mean, it's almost like the same answer, right? These methods can be learned. Women are increasingly learning them. and women want to learn them. I think actually if we just accepted that this was really happening, which it seems as though, I mean, increasingly in my life and in my colleagues' lives, people are actually doing this,
Yeah.
um, patients and providers and people are learning this and doing this. So this is really happening. I think we just need to move on and accept it and just start dealing with it and talking about it and offering it to patients and and telling our friends when we're charting or we're thinking about charting.
I love that. Now I want to get a t-shirt that says fertility awareness, it's happening, deal with it.
Really? Right? This is
That's
okay,
awesome.
people. The world will not collapse because people are charting their cycles and choosing how and when to have intercourse. It's going to be okay.
Okay, well, one last question, which I also love to ask, but for a woman who's listening, she's tuning in, and maybe she's on the pill, maybe she's not. She's not ready to have a baby right now, but she's planning to in the next 2 to 3 years. What, if anything, in terms of advice, would you give to her?
Yes, this is a situation I encounter in the office almost daily.
Hmm.
I would say this is a lot of women, right? I mean,
Yeah.
hopefully at least some of your listeners are saying that's me, or that was me a year ago, or that'll be me in a year or two, right? I mean, there's a lot of women. So I do see a lot of young reproductive age women who are thinking maybe someday they might have children. And so what would I tell her? Uh, and you said she's currently using a hormonal contraceptive or no?
Yeah, let's say she's currently on the pill
Okay.
or whatever hormonal
I was
contraceptive.
going to say, or any hormone,
Yeah.
artificial hormone method. So I would say to her, well, I have to be honest, I'm not really quick with these answers, Lisa. I always ask her about her baseline cycle. Does she have any idea what her baseline cycle is? And how long ago did she have a baseline cycle? Was she on hormones for 15 years? Which
Mm-hmm.
is really increasingly the norm to go on hormones in your early teen years and just stay on them for 15 or 20 years. So I asked her about a baseline cycle and how long ago that baseline cycle existed, just to give each of us a clue and to get her thinking about what her underlying fertility might possibly be. And
Mm-hmm.
then I also just share with her that return of fertility may occur within a few days or couple weeks, or it may return up to 18 months after stopping a hormonal method.
Mm-hmm.
So 0 to 18 months is actually considered, uh, that's what happens.
Yeah.
um, and so I tell her that I cannot accurately predict when her fertility will return. But I do tell her that I hope that she'll think about that and maybe think to come off 6 to 12 months before she wants to conceive, although that may not be enough time. And I
Mm-hmm.
also do tell her that I think it's important that she has 3 normal heavy bleeds before she attempts to conceive.
Mm.
Um, that's sort of a guideline that I give people. Normal heavy bleeds. So normal meaning occurring about a month apart, not like I had a cycle and then I had one in 4 months and let's get pregnant. And heavy, not these light artificial withdrawal bleeds that are barely there periods.
Mm-hmm.
Of course, they're not periods, they're withdrawal bleeds, but that would imply that the endometrial lining is not thick enough to sustain
Mm.
early pregnancy. So I tell her, your fertility might return in a few days or a few weeks, or it might return in 18 months. I don't know. And I would advise that you come off 6 to 12 months in advance or longer if you're interested. And I would recommend you wait for 3 normal heavy bleeds before you attempt to conceive.
Oh, I love that. So I think that's amazing advice. Well, Danielle, I could keep talking to you until Christmas, so I think I'll try to hold myself back. But thank you so much for being here today. I really enjoyed our conversation, and I feel like I say this every time, but I'm so excited to share our conversation with the listeners. I feel like there's so much that we talked about in this episode that's so relevant, to so many women's lives. And I think that this conversation is so important, and I'm just really happy that we were able to have it and share it with all the listeners today.
I'm thrilled to talk with you, Lisa, and I'm thrilled that women are learning about all the great topics that you're bringing to your Fertility Fridays series. So thanks for having me.
Thank you for listening. If you enjoyed today's show, please share it with a friend. Danielle has provided me with some additional information. So if you were intrigued and inspired by our discussion of NAPRO technology, she's provided 3 websites. The first one is www.naprotechnology.com. The second is www.creightonmodel.com. And the third website is www.fertilitycare.org. And of course, you'll find these links in the show notes page, which is fertilityfriday.com/31. If you are wanting to actually find a NAPRO technology doctor, if you go to the Fertility Care website and you click on Find a Teacher, you can actually check your region and it will provide you with a list of doctors that offer services with NAPRO technology, so doctors that have been trained in the method. And if you do have a question for Danielle, she has asked for you just to contact me, so you can go to fertilityfriday.com and click on the contact me page and just send me an email and let me know that you want to be connected with Danielle, and I'll forward it along to you, or forward it along to her, sorry. As for me, you can find me on Twitter at Fertile Friday. As always, you can stop by the blog and leave a comment in the show notes for today's episode, which you'll find at fertilityfriday.com/31, as I mentioned before. You can also find me on the Fertility Friday Facebook fan page, which is facebook.com/fertilityfridays with an S. And also the Fertility Friday Facebook group, which you'll find at fertilityfriday.com/community. And if you've been enjoying the podcast, again, please look for it on iTunes and leave a 5-star review. Well, 5-star review would be awesome, but just leave an honest review, and that will just help more people to find the show. So again, thank you so much for listening. And as always, until next time, be well and happy charting.